Hello, it's Andy Shorr from Washington, D.C. with your Pulmonary and Critical Care Literature Review for the month of August. There are two articles that have recently been in JAMA that I want to share with you. I think they bear directly on the practice for those of us who are actively involved in the care of critically ill patients or working in hospitals for quality improvement or quality assurance. The first one deals with tight glycemic control, and the second one deals with ventilator-associated pneumonia. Both of these areas have been key efforts for focuses of process improvement and of quality of care. In fact, CMS, the Centers for Medicare and Medicaid Services, have suggested that hospital-acquired pneumonia, for example, is such a preventable disease that it will no longer reimburse for it. And organizations such as JACO are now holding hospitals to very high standards when it comes to tight glycemic control. Both of these articles bear directly on these issues and I think give important information to clinicians in terms of what options are available to them and where we know the science is currently going and what we actually understand and what we don't understand. The second trial I want to talk about, called NASCENT by Koloff and colleagues, dealt with the issue of ventilator-associated pneumonia. Ventilator-associated pneumonia, as I said, is a very burdensome disease. Estimated attributable costs of the disease probably range between $10,000 to $40,000 per event, depending on what you're looking at and how you're defining it. And although there's never been an attributable mortality described with VAP, there's certainly an attributable morbidity. What can we do for prevention? Lots of things we can do for prevention. Head of the bed elevation, early extubation, less sedation, all of these things have been studied, and unfortunately institutions don't always implement them. One thing I think we've learned about the pathogenesis of this disease in the last 5 years is that the tube itself is an important risk factor, and the biofilm that builds up along that tube is an important risk factor. Just as we see devices in terms of the biofilm growing, being a risk factor for bloodstream infection, for central venous catheters, the theory is, well, that might happen with ventilated patients as well. So what these authors did was study a novel endotracheal tube. It was a tube coated with silver in order to prevent biofilm buildup. They conducted the trial and randomized patients, non-blinded study, to either treatment with the standard endotracheal tube or with a silver-coated endotracheal tube, and bronchoscopically confirmed pneumonia served as the endpoint. Now, one of the limitations of this trial was that they had to enroll patients who they thought were at risk for progressing to need ventilation, so they weren't already ventilated. And we can't always tell that in the real world, right? I mean, these authors were working under the confines of a clinical trial, but we can't always tell exactly who's going to progress to ventilation and who's not, who's going to be alive at 48 hours and actually be at risk for VAP and who's not. So there are some nuances in the way that they actually conducted the trial. However, what they found was a substantial risk reduction in the rate of bronchoscopically confirmed VAP. Now, they saw no difference in mortality, but again, VAP isn't necessarily associated with attributable mortality, and the VAP rates in the study overall were very low, suggesting that these institutions were already doing something very aggressive to try to prevent VAP. Nonetheless, the benefit here was additive. I think the issue for clinicians is to realize how this as a tool fits in their armamentarium. The authors suggest that one of the advantages of a device like this is that it engineers the process, right? It takes thinking about head of the bed elevation, thinking about sedation out of the system. Conversely, however, all of those systems changes are options to us. So I think it's important to look at the panoply of choices and figure out which ones are best available to you or most applicable to you at your own institutions in order to determine which ones you want to apply. In the end, it always comes down to weighing risk and benefit. It always comes down to understanding the nuanced issues of the trials and the literature. And just to wrap up, in terms of disclosures, I served as a member of the Data Safety and Monitoring Board for the NASCENT trial, and I think it's important to be forthright about it. In conclusion, though, you do have a newer option, and I think both of these articles get us to question what we think we know about critical care medicine and about pulmonary medicine, and they actually make us think about what we're doing for quality assurance and prevention in terms of trying to keep up with the issues. Thanks so much, have a great month, and this is Andy Shorr from the Washington Hospital Center signing off.